If you will, come forward, Dr. Vicki Bowler. She's the Assistant Dean of the School of Population Health at the University of Mississippi. She will be facilitating the next panel.
Good afternoon, everyone. I have the absolute honor of introducing our new presenter. Dr. Karen Sheffield Abdullah is a certified nurse midwife and a nurse scientist whose interests focus on the utilization of holistic, integrative, multi-sector strategies to promote physical, mental, and emotional well-being for individuals and for communities. She is particularly interested in developing strategies to reduce the long-term health effects of psychosocial trauma, anxiety, and depression on women's health and birth outcomes. Please help me in welcoming Dr. Karen Sheffield Abdullah.
Good afternoon. All right, y'all still with me after lunch? Yeah? All right, very good. So thank you to the Glenn Foundation, Glenn Family Foundation for this invitation. I feel honored to be here, and thank you to my friend and colleague, Dr. Demita Barlow, for making that introduction. Truly grateful to be here, to be able to talk to you all about Black perinatal mental health, who's talking and who is not. And we'll jump right into it. I do just have a couple of disclosures. I have a couple of companies, Brave Company and Dr. Karen LLC. The work that I'm going to be presenting to you today have had multiple funding sources to include the NIH predoctoral fellowship and the NIH postdoctoral fellowship, as well as Sigma Theta Tau Alpha Alpha chapter, amongst others. And in my introduction, as you already heard, I've come to this place, kind of a circuitous pathway, if you will, in that I actually have a bachelor's of arts in physics. I worked as a chemist for many, many years at a pharmaceutical company y'all might have heard of called Pfizer. And I did the quality control testing for novel drug compounds to test the purity and potency of those drugs. And then, after the birth of my second child, who was delivered by a nurse midwife, everything changed for me. And I decided that I wanted to go back and become a nurse midwife. But before I became a nurse midwife, I became a doula. So a lot of what has been said up until this point has been resonating with me, with all of the different speakers. I've been seeing a little bit of how this is all weaving a really nice story. After the birth of my second child, I decided to go back to school to become a nurse midwife. And after I became a nurse midwife, I became the director of my own nurse midwifery practice in Connecticut. I'm from Connecticut, born and raised in New Haven, Connecticut, and am the descendant of Jamaican parents. So there's so many threads as I think about all of the speakers and moderators today. So really, if you don't remember anything else today about what I am passionate about all things women's health. I am passionate about mental health, and I'm passionate about integrative health approaches like mindfulness. And so I hope that as I share with you today, you will be able to take a little bit from what I'm sharing with you about why it is so important for us to be thinking about Black perinatal mental health. So anyway, I just kind of gave you the segue into what this slide kind of was saying, which is I've gone through the path of how I came to this place and this point. What I will say is that after I became a nurse midwife, I decided that I was done with the Connecticut cold. I was over it. If y'all haven't noticed, I'm the one that's walking around with the blanket on today because I forgot my shawl. I am always cold, but I got tired of Connecticut cold, moved to North Carolina, where I became clinical faculty at UNC Chapel Hill School of Nursing. And very much like Dr. Barlow, I'm a why person. Why do we do what we do? People either like that or they don't, because I'm always going to question, but why, but why, but why? And so I decided to go back for the PhD at UNC School of Nursing from 2013 to 2019. and then did a postdoctoral fellowship in the School of Medicine at UNC in the program on integrative medicine, because I was so interested in how we can think about providing non-pharmacologic or non-medication ways of addressing mental health for pregnant and postpartum populations. And it was really based on what I was seeing in clinical practice. What I was seeing in clinical practice is a lot of individuals coming in during their annual exams, and I actually took the time to talk to them and say, so what's been going on over the last year? And a lot of people would say things like, man, I am stressed. I have a lot happening, but they wouldn't necessarily call it depression or anxiety, but they would say things like, I'm just agitated, I'm irritable, folk getting on my nerves, I can't sleep, right? But they didn't necessarily say, I feel anxious or I am depressed. And I took the time to listen to them. And what we found, and what I found, is that I was seeing more and more patients who were coming in with psych mental health concerns because I was listening to them. And I also knew what was in my wheelhouse, and I would start them on medication or maybe 1 or 2 medications, but they would also have a therapist. Here's my bias as we talk about biases. We all need a therapist, y'all, and your therapist need to have a therapist too, right? Ain't nothing wrong with normalizing the conversation about the importance of having a therapist and the stigma that we have with saying that we're seeing a therapist. You can call him your life coach, it's okay, right? But whatever it is, we need to be able to have support to talk through the very real stressors that we experience in this here life. As my research assistant says to me all the time, Dr. Karen, life be lifing, right? Life is happening across socioeconomic status, across educational status. It doesn't matter. Life is happening to each and every one of us. And I feel very strongly about normalizing this conversation surrounding mental health. And also, just as a little segue to the previous panel, I did work also on the North Carolina Maternal Mortality Review Committee as a nurse abstractor, looking at all of the overdose and substance use related deaths, maternal deaths. And currently, as we think about solutions, I am partnering with the CDC and the American College of Obstetricians and Gynecologists to develop a tool that will determine the ways in which discrimination, interpersonal racism, or structural racism have contributed to a maternal death. So my team and I are currently, I'm on the working group, what's called Working Group 2. On the Working Group 2, we decided what should go into the tool, but it's too long for abstractors to use. So now we're utilizing Working Group 2, and I'm leading that to really think about how MMRCs and how abstractors can look at a record and determine, look at all of the medical records, prenatal records, emergency room records, and read through the notes to determine, did discrimination play a role in this person's death? Did interpersonal racism play a role in this person's death? Did structural racism play a role, right? Because it's not always explicit. It's surprising when we sit on MMRCs and we think about, oh, well, we can't really say whether or not discrimination played a role because it's not written. Well, can I tell you that healthcare providers, we don't write when we're discriminating against people, right? We're not writing that explicitly, but it shows up in different ways. And so our hope is to develop a tool where we will help the abstractors to think about, oh, this is missing, and that is an aspect of discrimination. Or this person had a substance use disorder. She has a history of, let's say, an operation or a hip operation. She has pain. She's well controlled on whatever medication she was on, but during pregnancy, we decided to take her off of her Suboxone or take her off of her medication. Now she's looking for ways to address her pain, but as healthcare providers, we don't want to give her the medication to help that pain because, oh, she's a substance abuser, right? And then what happens? Potentially, she overdoses on medications to address that pain. And that is the way in which discrimination can contribute to a maternal death, right? So thinking about things in different ways. I love this quote by Dr. David Satcher, former US Surgeon General. You cannot have health. There is no health, y'all, without mental health, right? That mind-body connection. When you think about the ways in which a stressor or stress comes in, how does it manifest in the body? Where do we feel it? In that earlier slide, I should also mention that I'm a mindfulness instructor, trained through Brown University's Mindfulness Center, so I often think about the ways in which the mind and the body connect. So when we talk about maternal mental health, we know that maternal mental health conditions are the most common complication of pregnancy and birth, affecting over 800,000 families each year. And 75% of women impacted by maternal mental health conditions remain untreated, increasing the risk of long-term negative impacts on both mothers, babies, and families, right? So if we think about the fact that, especially for the Black community, we are at a higher likelihood of being impacted by a maternal mental health condition, but we are half as likely to seek care or seek treatment. So think about why that might be. We also know that untreated maternal mental health conditions are a $14 billion cost to this country. And if we want to break it down by mother-infant dyad or mother-infant pair, that cost is $32,000. So the reason why I mention this is that somebody was talking about how do we affect change? How do we affect change at the policy or legislative level? When you start talking about money, people start paying attention. When you start talking about the cost, right? If we think about the preterm birth, right? And that it's a $26 billion cost to this country per year, you get people's attention. Oh, let's see, what can we do? What are the interventions that can be involved in impacting true meaningful change? So what are the numbers for Black perinatal people? Let's see if we can get the slide up. So I already talked a little bit about what we have here. If you can just scroll up a little bit, Jay, I wanted to get to the lower part there. Okay, thank you very much. So, great. So some of this has already been said, but we know that Black women, birthing people, experience maternal deaths 2 to 3 times the rate of white women. I would love to get to a place where we don't have white women as the comparator, right? How about we just say what the rate is, and just that's enough to know that the disparities exist, they're abysmal, they have persisted for decades, and we need to do better, right? So just thinking about that aspect of things, and as I mentioned already, approximately 50% of Black mothers will experience a maternal mental health condition. I actually think that this number is probably higher. Why do I think it's higher? I think it's higher because, one, we're probably not screening Black women, and I'll get into why I think we're not screening them as much. And I also believe that the existing screeners that are out there, like depression screeners like the CESD or the Beck Depression Inventory, or the anxiety scales that are out there, right, like the GAD-7 or the PHQ-9 or the EPDS, which has a couple of anxiety questions on it, they are not capturing the unique and nuanced ways in which Black women and birthing people or Black community talk about their stress, their anxiety, and their depression. These questions were not set up to really capture that for us, right? And so how do we think about developing culturally tailored or culturally relevant, culturally adapted screeners that are really asking the fundamental questions that will really get at anxiety and depression for our population? I will also tell you that I had the great pleasure of working with the Black Women's Health Imperative here in Mississippi doing a study over the last year where we asked Black pregnant and postpartum women, and I did something called cognitive interviews with an anxiety scale with them. Okay, so it was the Perinatal Anxiety Screening Scale, also known as the PASS. And basically with cognitive interviews, what I do is I ask, it's a 31-item scale or survey or questionnaire. And I ask them each question individually to get at what are they understanding the question to be asking them. And tell me what that question was asking them. To see, are we really getting at anxiety in the way that we think we are? Or are they interpreting the question completely different? So I don't want to overstate the results yet because we haven't written the paper on that. But the thing that's really interesting is the past starts off with, over the past month, how often have you experienced the following? I stopped there and I said, what is the past month? When I say over the past month, what does that past month mean to you? And let's say, what's today? April, what, y'all? 18th? Some people would say, oh, well, if we're talking about the last month, March 18th. Some people would say the last 28 days. Some people would say, oh, the last 30 days. Some people would be like, oh, February, January, So the last month can mean something very different for different people, right? And then the next question was, over the past month, how often have you experienced worry about the pregnancy/baby? When we look at that, how do we know if that person was answering the question about the baby or the pregnancy? That's called a double-barreled question, right? So when we're wanting to be able to discern really what their worries are, we should separate that question into two. It's not one question. And then one other item that was really interesting is it said, over the last month, how often have you felt like you're watching your life like you're in a movie? Now that question is trying to get at dissociation, right? I will say that the majority of the individuals who I interviewed answered, girl, yes, I feel like I'm in a movie. I can't believe this is my life. They are not dissociating. So when they answer or they score themselves at a certain level on that question, we could be making assumptions that they're dissociating when in fact they're saying, I can't believe this is my life right now. Or I can't believe this is what's going on. Yes, I feel like I'm looking at my life as a movie. So really, really interesting to think about, are the existing screeners that are out there, are the existing questionnaires that are out there accurately capturing mental health concerns for our community? And my argument is that no, it doesn't. And I actually think that these numbers are actually quite high. In full transparency, my bias is that we study depression a lot. We do not study anxiety nearly enough. And in fact, we know that anxiety is quite prevalent during the perinatal period, and we are missing it, okay? So I'm ready to move on to the next slide. So the CDC, I think this was back from 2020 data, right? So they talked about mental health conditions are the leading cause of maternal deaths, and that suicide and overdose are the leading cause for death for women in the first year following pregnancy. When I talk with my CDC colleagues, and this got a lot of attention in the press, but the important thing to understand, when I was talking with my CDC colleagues, what they said is that this is not necessarily the case for Black women. For Black women, the leading cause of death is still cardiovascular or cardiomyopathy issues. But that didn't get nearly as much attention. This got attention, but really we need to make sure that we're understanding it in its totality and understanding that it is different for different communities. I won't spend a lot of time on the perinatal substance use disorder, but just wanting to mention that approximately 7% of individuals report prescription opioid use during pregnancy. Nearly 14% of pregnant people report drinking alcohol. 17% of pregnant individuals use licit or illicit substances during pregnancy. As you can imagine, there's very limited data on cocaine use and methamphetamine use during pregnancy because how do we really do those studies, right? It's usually retrospective. And it's hard to know the full extent of perinatal substance use due to the underreporting because folks are worried about the consequences if they report it. So when I ask individuals, are you having conversations with your healthcare providers surrounding your mental health concerns or your substance use disorder concerns? There is a resounding no, I am not. And the reason why is they will say things like, well, I don't need CPS showing up after I have my baby, right? On the postpartum unit, all of a sudden social work has been called, CPS coming in just because I had a moment of wanting to divulge to my healthcare provider something that I thought we could have a conversation about, and they took it and went somewhere else with it. So there is a very real fear of what happens when we divulge or when we share. We already talked a little bit about this, but just to give you some statistics, approximately 26% of individuals experience perinatal depression, and approximately 21% of individuals experience perinatal anxiety, but you all already know my bias. I think these numbers are higher. In 2020, the number of people living with anxiety and depressive disorders rose significantly because of COVID-19 pandemic. Here's what I have to say about this. I think there were concurrent pandemics happening. So how do we know that the anxiety and the depression rise that we saw was only related to COVID-19, when we certainly know that there was racial injustice, social injustice, racial unrest happening concurrently at the same time that might have made certain communities feel anxious and depressed, right? So how do we pull out that data to be able to say, how do we know it's just related to COVID-19? I'm not underplaying what was happening regarding COVID-19 and how that contributed to our anxiety and depression. I'm inviting you to think about, and also, this was happening at the same time. So my formative work and my predoctoral work really centered around gaining a better understanding of the individual and perceived factors that may contribute to the persistent racial and ethnic disparities in Black women's pregnancy outcomes. So we've already talked about this, but Black women and their infants have twice the rate of preterm birth and low birth weight compared to white women and their infants, and this disproportionate rate of adverse pregnancy outcomes persists even when we control for factors such as maternal education, socioeconomic status, and prenatal care and health behaviors. What we know is that a PhD prepared Black woman will have worse outcomes than an 8th grade educated white woman. Why is that? How can that be? And these statistics have persisted for decades. This is not new. I know that it's getting a lot of attention. Maternal morbidity mortality is very, people are just very high profile right now. I think some of that has to do with the Serena Williams of the world, right, who come out and talk about what her pregnancy outcome and pregnancy postpartum experience was, or Allison Felix, or Beyonce, right, who are coming out to say, this has happened to me. But what's really interesting and what we need to be thinking about is that as Black women increase in educational status and socioeconomic status, our outcomes continue to be abysmal. And it's, in my opinion, unacceptable, and why I'm really passionate about this work. What do I think is important to consider about the lived experience for Black women in this country? I think that we may have been missing over the last several decades. I'm a stress and anxiety researcher, right? So I'm really interested in how maternal stress may explain these disparities due to the social disadvantage and minority racial ethnic status that is characterized by higher levels of psychosocial stress and inadequate resources. And as has already been elucidated and talked about today, Black women experience greater levels of stress compared to white women. We know this to be true. It is borne out in the literature. I have the citations there for you. But really to be thinking about the stressors that we experience at the intersections of racism-related stress and gender-related stress. Therefore, it is really important for us to be exploring the role of the unique factors of stress in Black women and their contributions to our psychological distress. And when I say psychological distress, I mean anxiety symptoms and depressive symptoms. As a predoctoral student, I often said, I want to study anxiety, I want to talk about anxiety. And what I was told is, Karen, anxiety is not fundable. Nobody's going to fund that. So you have to operationalize it within the words of psychological distress to be inclusive of depression. So when you see me say psychological distress, just know in the back of your mind, I was really thinking anxiety, okay? But for the purposes of getting my PhD and being able to graduate, I called it psychological distress in my papers and in my assignments. So thinking about the ways in which we experience stress, and I incorporate fundamentally the conceptual frameworks of superwoman schema and network stress to highlight factors that may contribute to stress and psychological distress in Black women. And I know this came up earlier as well. I got excited when somebody was talking about, this idea of we can do it all. And so superwoman schema, let's talk a little bit about that. How many people have heard of superwoman schema or strong Black woman? Good number of folks. Okay, so superwoman schema is a conceptual framework that was developed by Dr. Cheryl Woods Giscombe. She was my dissertation chair. She's a mentor, a colleague, and she is currently the senior interim dean of academic affairs at UNC Chapel Hill School of Nursing. She's my boss. And basically, this conceptual framework states that there are certain historical and sociocultural events that have happened in this country related to race and gender that have caused many Black women, certainly not all, but many Black women, to develop 5 hallmark characteristics. They are an obligation to manifest an image of strength or stoic exterior, an obligation to suppress emotions, resistance to being vulnerable or dependent, a determination to succeed even in the face of limited resources, and an obligation to help others or caregiver role, even at the detriment of our own health. All of that, yes, 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 yes. And also, another framework that I utilize is network stress. And network stress is simply the perceived stress related to the stressors in the lives of family members, friends, and loved ones. So that's just a fancy way of saying that I have stress from my family, my friends, my loved ones. And for Black women, in a study that was done by Dr. Giscombe in 2015, what they found is that for Black women, we appraised the stress of our family, friends, and loved ones the same as our own self-stress. So if my best friend is going through divorce, y'all, I'm going through that divorce with her. I am stressed, right? If a loved one is going through a sickness, I am stressing about that, the same as I stress about my own issues. So what's important to think about is that as we think about solutions or interventions or programs to address stress in Black women, we have to think about their network and the demands that their network may be making on them, knowingly or unknowingly. And certainly as we think about why outcomes might be more concerning for Black women as they increase in educational and socioeconomic status, let's think about the network. Right? The network might be pulling on her a little bit more or asking more of her because they think, well, she's resourced or she has X, Y, and Z. Can you just help me out? And that adds a layer of stress for us. So what can we think about? Well, as I mentioned to you, I'm very passionate about integrative health approaches, and in this schematic, what I want you to just kind of draw your attention to is, in the orange, the mind and body practices like massage, like acupuncture, like yoga, like Tai Chi, and mindfulness. And then we have natural products like you would imagine, like botanicals and herbs. But really, what the research shows is that mind-body practices have been associated with decreased pain, decreased anxiety symptoms, decreased depressive symptoms, decreased stress, and increased quality of life, increased well-being, and increased healthy behaviors. So why specifically complementary and integrative health approaches? Well, during the perinatal period, they've been shown to be effective in decreasing psychological distress. And also, there are very few studies that have examined looking at integrative health approaches for Black women. And to my knowledge, as of 2024, there's only one study that has looked at integrative health approaches for Black perinatal women, okay? So mindfulness is what I'm particularly interested in. And what is mindfulness? Mindfulness is, using John Kabat-Zinn's definition, John Kabat-Zinn created mindfulness-based stress reduction over 40 years ago. And he talks about it being paying attention in a particular way, on purpose, in this present moment, to what is actually happening or what is arising, and doing that in a non-judgmental way. The way that I think about this is dialing down the noise. Being present in this moment, a moment you will not experience again. And what is coming up for you in this moment? And why is it important for us to think about that for Black women? I think it's important because oftentimes we have so many competing demands going on that we can't get quiet enough to notice the subtle changes that are happening in the body. The body talks to us in whispers, y'all. It's just whether or not we choose to listen. It might start with a little eye twitch. Your cheek twitches a little bit. You got a little bit of a headache. Oh, my back is hurting a little bit. But you're not really paying attention to it because what? We're going and going and going and going and doing and doing. And mindfulness invites us to shift from that doing mind into just being. Being with what is here. And that might help me to recognize, oh, this headache is different than any other headache. I need to call my doctor. Oh, something doesn't feel right. And I am on any platform that I am invited to speak on, I often will share, especially with my healthcare colleagues and my OBGYN colleagues, who say, Karen, what can we do differently if I'm speaking at Grand Rounds or something like that? And I'll say, when a Black woman says something is not right, believe her and listen to her. Because what it took for her to show up in front of you and actually say something isn't right, she probably spent, 10, 15 minutes convincing herself, oh, it's not that bad. I'm all right. It's okay. Why? Stoic exterior, resistance to being vulnerable, emotional suppression, right? Fear of the healthcare system, medical mistrust, distrust of the healthcare system. So when Black women are saying something isn't right, believe them. I can remember distinctly one of my patients early on who came into the office. I'd say she was in her mid-20s, about 26, 27 weeks pregnant. And she just didn't look right, but I was new enough that I was like, I don't really know what's going on. I don't really know what's going on with her, but I know something isn't right. And she said, I just feel off. I just feel like something just isn't quite right, Karen. I don't know what it is. But I knew enough to want to get some labs, and I knew enough to check her blood pressure, and it was the end of the day, and I think we sent her over to the hospital to be evaluated. She was one of the most sickest patients that I had ever had that developed preeclampsia and ended up with HELLP syndrome. She was so sick. And it actually presented before any of the labs really went off the charts, right? And so the idea is, imagine if I dismissed, I just don't feel right. You'll be all right. Check in with me tomorrow. We have to listen. And also, if we're equipping Black women with the key coping strategies and stress management skills to be aware of what is coming up for them in their own body, they're more attuned, they're more aware to say, wait a minute, you need to listen to me. I'm telling you something isn't right. And helping them to understand, to trust what they know to be true for them, right? Super important. So what mindfulness is not, it's not meant to be religious or spiritual. A lot of people will often say, Karen, I don't know what you're talking about with that mindfulness. What you doing over there? You trying to convert me to Buddhism? What are we doing with that yoga? What's going on, right? And that's not the case. Yes, while mindfulness has its fundamental core precepts and tenets based in Buddhism. Mindfulness-based stress reduction, which is what I am trained in or educated in, we are not teaching Buddhist principles. Okay, it's not meant to be religious or spiritual. Although I will say that when I do mindfulness with Black women, and we've asked, when in certain studies, we've asked Black communities to say, is there anything about your core fundamental spiritual beliefs that made it hard to incorporate mindfulness into your day? They were like, no, it worked. When I got quiet, I was able to hear from the Lord. When I got quiet, I was able to pray. Right? So it's not coming up against each other. It can actually work quite beautifully and synergistically. It's not meant to be a magic or a silver bullet. It's not always about feeling good. You can feel good after practicing mindfulness, but it's not about striving to feel good. It can reduce stress, but it's not always about stress reduction. It's not about being calm, although you can achieve calm. And it's not about being complacent. There's 7 different attitudes of mindfulness. In the interest of time, I'm just going to list them here. One of my favorite is non-judging. And I think that's very helpful for many in the Black community. We already do a lot of talking to ourselves, perhaps negatively. And so I like to make sure that I tell folks there's no judgment. When you know better, you do better. There's no judgment. Okay? Patience with ourselves and others, a beginner's mind coming to each meditation as if it's the first. Trust in what you know to be true for you. Non-striving meaning I'm not trying to achieve a certain state. Acceptance, that's a hard one for me, right? So acceptance of what is here. Doesn't mean I like it. It just means that I recognize, I accept this is what is here in this moment, and then how do I proceed? And then letting go of that which no longer serves us. I loved what was said earlier. No is a full and complete sentence. And that can be said to family, friends, loved ones, your network, right? Letting them go. It's going to be a no. Other ways that I have found people talk about it. I just don't actually have capacity for that right now. I don't have the bandwidth for that right now, right? So bandwidth capacity. The other thing that's really important to mention is as my research and the work that I want to do is to examine and explore stress and anxiety in perinatal Black individuals, but to develop a culturally tailored, trauma-sensitive, person-centered, mindfulness-based program targeting their stress and anxiety. And the trauma sensitivity needs to be important because of what we already talked about earlier today. But the work by Dr. David Trelevin states that over 90% of us will experience a traumatic event at some point in our lifetime. And if that's the case, it's really important as we think about developing programs and interventions to make sure that we are doing it through a traumatic sensitive lens, if you will. I would argue that 100% of us will experience some type of trauma in our lifetime. I would argue that the concurrent pandemics that happened earlier, that was trauma. And I still think that as we are going through day to day, there's trauma that exists within this world. The last 4 years, 4 months, 4 weeks, 4 days. So I did a study, a mixed method study, and I'm a mixed methods researcher, which means I'm really interested in surveys, right, or questionnaires, like what we just talked about, an anxiety scale, a depression scale. But I'm also really interested in the qualitative side, where I actually ask questions, because I think that the surveys only tell you one part of the story. It just tells me, oh, they scored this level on an anxiety screener, or they scored like this on depression. But when we do the qualitative interviews and we actually ask people, well, why are you anxious? You know, what's coming up in terms of your anxiety symptoms? What's coming up in terms of depression? That adds context that we would not otherwise get by just looking at scores. So in this particular study, there were 125 participants, and you can see that they were demographically diverse across different criteria: relationship status, educational attainment, and household income. But what I want to draw your attention to is I asked them, of the following medical conditions, please tell me which ones that you had. Look what they said, y'all. I gave them the Spielberger State Trait Anxiety Inventory, the Perceived Stress Scale, and the CESD. They scored high for anxiety. They scored high for perceived stress, and they scored high. Anything 16 or greater is considered clinically significant for depression on the CESD scale. Let me just see. What I wanted to draw your attention to here in the red box, what was the most commonly reported medical condition by Black women? They actually said anxiety. 27% said that they had anxiety. That's significant, that they even admitted it and they checked the box to say that they were anxious. And then followed closely by 23% said depression. We know that depression and anxiety are often what we call comorbid or come together, but not everybody who is anxious is depressed, right? So let's really think about how are we addressing individuals' anxiety? And how do we think about taking the label off of it and saying, oh, that person is anxious, or I have a depressed patient, or I have an anxious patient? Could we think about language that sounds like this is a patient who is coping with the symptoms of anxiety? She is not her diagnosis. She's an individual coping with anxiety, an individual coping with symptoms of depression. Do you see the difference in the reframe than putting a label on the individual? Yes, we have to write a little bit more as healthcare providers in our note, but I think it's worth taking the time to think about destigmatizing how we label individuals. I also did some correlational analyses where I looked at Superwoman schema. Remember the 5 hallmark characteristics of Superwoman schema. It may not surprise you to know that for those individuals who endorsed higher levels of Superwoman schema, emotional suppression, right, stoic exterior, determination to succeed, resistance to being vulnerable, caregiver role, they had higher levels of anxiety symptoms, higher levels of depressive symptoms, and higher levels of perceived stress. Conversely, they had lower levels of mindfulness, lower levels of self-compassion, and lower levels of mindful self-care. So qualitative findings, again, this is when I actually did interviews with them and asked them, when I say the word stress, nobody had fundamentally asked this question of Black perinatal individuals. When I say the word stress, what does that mean for you? Look what they said. Y'all know I told my dissertation committee, I said, I told y'all anxiety was a thing. They said it. So not only did they score high on anxiety, when I asked them what stress meant for them, they said anxiety. They said overloaded. They said overwhelmed. That's how they're defining stress for themselves. And then when I said, is there anything uniquely stressful about being pregnant? As a nurse midwife of 20 years, I have my own biases about what I think those stressors are. Yes, I think there are unique stressors to being pregnant, just physiologically on the body and also just mentally. But I also asked, is there anything uniquely stressful about being Black and pregnant? And here's what they said. The judgments and assumptions that are made about them by society, the isolation that they can feel, and also one of the themes was the stress that they experience from their network. So this is a quote from one of the participants in the study, and she said, I don't look my age. I'm 28, and so one of the things that stressed me out when I was pregnant was people would just give me a dirty look. Like, oh, there's that Black girl, she's probably not married and she's young. But I'm not unmarried, I'm 28 and I am married, but you would just get those looks. One of my appointments I went to, they asked me, was the father in my life? And I'm like, yes, my husband is at work. And he couldn't come to the clinic today. That was stressful because you had to be on guard. Like people assume that you're Black, you're unmarried, you're on welfare or something. But I'm not. Like I go to places with my baby and they'll say, are you going to pay for this with food stamps? And I had to respond, no, I don't qualify for food stamps. That is stressful. Like, I don't know why people assume these things. So imagine as you're navigating the stressors of just being pregnant and Black, now you've got all these judgments and assumptions that are coming into play, that you are navigating microaggressions, macroaggressions, gaslighting, even at your prenatal visits, that the global minority does not have to experience. Thinking about isolation, they were talking about, and not having people understanding that if we come to talk, or we come to say something, or we come to say this, we don't want to get bashed for it. We just want that ear. And then when we don't get that ear, it's a sad place when we have to stand alone. So you can imagine that this individual may have been talking about the fact that she was feeling having a vulnerable moment, wanted to share something, but felt like she was going to be bashed or judged or made to feel less than if she shared it with that person. And then what do you think happens when somebody does that? For instance, one of the participants mentioned that the father of the baby was married. Somehow, they put that in her chart. And every subsequent appointment, the provider would say, oh, what's going on, with father, baby? My understanding is that he's married. And she said, take it out of my chart. It has nothing to do with this pregnancy right now. Listen to my baby's heartbeat. Do what you need to do to address my concerns. Unless she brought it up, that's when it would have been appropriate, right? If she's saying this is a stressor. But for it to be flagged in her chart and then be asked over and over, that was an issue. That's a concern. And then the network stress, right? My route of life is non-traditional compared to the rest of my family, and so they look at me as this role model, or they put me on this pedestal. So basically, I don't want to be there. I don't want to be that. I have to keep up a persona. Like, I have to be perfect. I have to be not be stressed out or be worried about anything, because they've all looked at me or look at me as an example for their children or for their lives. So you can see where that network stress comes into play. Is it time for questions? Yeah, I gotta wrap it up. Thank you, Dr. Helen. So conversations with their healthcare providers, I already talked to you guys about this. When I asked them, are you having conversations with their healthcare providers about their stress and psychological distress? It was a resounding, no, we are not. Then I asked an important question. I said, would you have wanted to be asked? Thinking about how my business is my business. I don't need everybody in my business, right? So I wanted to know, would you have wanted your healthcare provider to ask you about your stress or your psychological distress? And they said, yes, but only if. And the only if is if I tell you that I need help with my mental health concerns, are you going to be able to put me in touch with the resources, with the mental health care provider who is going to be stellar? They don't want mediocre care. They want stellar care. They want good providers. They want people who are going to listen to them. And they also want somebody who's going to take their insurance. Please do not refer me somewhere where they have this long waiting list, and then I find out that they don't even take my insurance, right? Because what happens with this population? When you have a pregnant individual with a mental health concern, OB says, uh-oh, that's mental health related. You got to go over to psych. Psych says, you're pregnant, you got to go over to OB. And then it's left for that person to navigate the healthcare system to advocate for themselves. And the onus should not be on the patient to be trying to advocate for themselves to receive good care. So with that, I'll just leave you with, there are resources that I've listed here from different organizations. And I think these slides will be made available to you all. But I've listed lots of different therapy resources for Black birthing people and women. And then finally, if you'd like to contact me, feel free to contact me at the what I have listed here. Thank you so much for your time.
Thank you so much, Dr. Abdullah Sheffield. We would now like to open the floor for questions. Does anyone have questions? Please come to the mic if you do. I'll get us started as you come forward. But I really appreciate learning more about the Superwoman schema. I'd like to reiterate that Dr. Beatty says this often, Black women have big hands, is how she describes it when we have these conversations. It's already hard for Black women, as we have heard today, to get the care that they need, but how can healthcare providers, clinicians, those people on those teams effectively communicate the benefits of integrative health approaches in a way that resonates with their cultural beliefs and experiences when it's already so hard for them to just get normal prenatal care?
So the question is, how do we communicate as healthcare providers to our patients the importance of integrative health approaches? Yes. So what's really interesting is that during pregnancy, women tend to be very motivated to engage in different modalities to help their stress or help their mental health. And so I don't know that it's that hard of a ask or that hard of a sell, actually, to at least educate individuals. And also, we talked about centering pregnancy or group prenatal care in the past earlier. Mindfulness, there are certain components of mindfulness actually in centering pregnancy. And one of the things that I've been asked to do is to be able to help develop the curriculum such that we integrate more culturally tailored mindfulness into centering pregnancy. And I think that's a really great way to give individuals an idea of what it could look like, right? If we're able to spend time with them thinking about non-medication ways of addressing their stress. There's nothing wrong with medication. I highly advocate for those to stay on their medication if they're on medication. Pregnancy is not the time to get off it, right? But also be thinking about what are some other ways that we can address their stress and psychological distress. And so I try to do my part in speaking, right? And also going out and doing grand rounds with healthcare providers to talk to them about these are different ways that we can be looking at providing integrative health approaches to our patients, and at least starting to have the conversation. Yeah, I think we're out of time.
Thank you.
Yeah, thank you.
If there are no other questions, thank you so much.
I was going to say, am I hopping down?